A 71-year-old female presented with nausea, postprandial right upper quadrant pain, and possible pancreatic duct dilation on CT abdomen. She had a liver transplant in 2012 for hepatocellular carcinoma secondary to hepatitis C, with an anastomotic stricture managed by sequential plastic stenting. She also had a background of atrial fibrillation and hypercholesterolemia. The pancreatic duct was of normal caliber for her age in the body and tail of pancreas, and the parenchyma appeared normal. As the duct was traced towards the neck of pancreas, it became ectatic and dilated, and the surrounding pancreatic parenchyma was more hypoechoic than the adjacent tissue. A mural nodule was seen within the dilated duct, as well as the dilated side branch. The pancreatic duct measured 8 mm in the head of pancreas, and a decision was made to sample the hypoechoic periductal tissue. 3 passes with a 25-gauge needle from the duodenal bulb were made. This was diagnosed as IPMN with moderate dysplasia. The question is, what is your management plan? A 6-month surveillance EUS, B, a 12-month surveillance EUS, C, obtain an MRCP, D, repeat the EUS FNA in 3 months, or E, obtain a surgical consultation for a Whipple's resection. Main duct IPMN with a duct diameter of 8 mm and a mural nodule with cytologic dysplasia are high-risk features for neoplastic progression, and surgical consultation should be obtained. A 61-year-old female presented for EUS evaluation of a 10 cm exophytic body of pancreas mass on CT abdomen, performed for evaluation of abdominal pain. She had a recent history of short segment ischemic colitis and a background of type 2 diabetes mellitus, osteoarthritis, and previous transient ischemic attack. An irregular mass was identified in the body of pancreas, measuring 90 by 80 mm in maximum dimensions. It had a heterogeneous echotexture containing microcystic and macrocystic areas and solid components. A central hyperechoic area with acoustic shadowing was also seen. Fine needle aspiration using a 22-gauge needle was performed. The question is, what are your differentials? A. Pancreatic adenocarcinoma, B. Neuroendocrine tumor, C. Serous cystadenoma, D. Pseudopapillary cystadenoma, E. Mucinous cystadenoma, or F. Malignant progression of main duct IPMN. The in-room cytology assessment found multiple uniform, small and dark cells, which was consistent with a diagnosis of neuroendocrine tumor. An 86-year-old female presented with abdominal pain and a tail of pancreas mass on CT abdomen. She was a newly diagnosed diabetic and had well-controlled hypertension and hyperlipidemia. On imaging from the second part of the duodenum with a linear echoendoscope, the aorta was at first identified and the uncinate process appeared on gradual withdrawal of the scope. There were multiple anechoic cystic structures within the pancreatic parenchyma. Some of the cysts appeared confluent. No debris or solid lesions within the cystic areas were seen. The main pancreatic duct appeared slightly ectatic but was not dilated. These changes were also seen in the pancreatic neck and body. As the pancreas was traced to the tail, a solid cystic, heterogeneous, well-defined lesion was seen, measuring 50 by 60 mm in maximum dimensions. It contained a number of hyperechoic foci. Peripancreatic ascites was also seen. The question is, what is the most likely underlying pathological process? A. IPMN, B. Serous cystadenoma, C. A solid cystic pseudopapillary neoplasm, D. A mucinous cystadenoma, or E. A neuroendocrine tumour. Two passes were made with a 19-gauge FNA needle using a transgastric approach. In-room cytology demonstrated large, bizarre pleomorphic cells with a high nuclear to cytoplasmic ratio within a necrotic cystic milieu. This was consistent with pancreatic adenocarcinoma. There was a question of whether it was arising from a serous cystadenoma or IPMN. Immunohistochemical staining for inhibin was performed, and its negative status suggests IPMN as the underlying pathologic process. The answer, therefore, is A. IPMN. A 76-year-old female presented with elevated liver function tests and dilated extra and intrahepatic ducts, and a dilated main pancreatic duct on CT abdomen and MRCP. She had a background of diabetes mellitus, hypercholesterolemia, hyperthyroidism and gastroesophageal reflux disease, and a history of cholecystectomy. On imaging from the second part of the duodenum with a linear scope, a markedly dilated common bile duct was seen, measuring 16.8 mm. The pancreatic duct was also dilated, measuring 6.6 mm. The ducts were carefully traced into the ampulla, assessing for strictures, stones, and masses involving the ducts, ampulla, and periampullary region. On pulling back through the duodenum, a dilated pancreatic side branch was seen, and the pancreatic duct measured 13 mm. The pancreatic duct was traced to the tail and was dilated the whole of its length. The extrahepatic duct was identified from the gastric body and traced towards the liver hilum, confirming both extra and intrahepatic duct dilation. The question is, what is the most likely differential diagnosis? A. Benign papillary stenosis, B. Type 4 choledococele, C. Pancreatic IPMN, D. Pancreatic and biliary IPMN, or E. Ampullary adenoma. The most likely differential is pancreatic IPMN causing secondary biliary dilation. Combined pancreatic and biliary IPMN is much less common than pancreatic IPMN alone. The ampulla appeared normal on EUS, and a diagnosis of a choledococele should only be made on excluding other pathologic causes of ductal dilation. A 68-year-old male had prominent gastric folds identified on an endoscopy performed for evaluation of abdominal pain, diarrhea, and recent loss of weight. He had a background of chronic alcoholic pancreatitis and hypertension and was on regular low-dose aspirin and omeprazole. A radial EUS was performed. The endoscopic evaluation confirmed thickened gastric rugal folds in the proximal stomach with a normal stomach distally. No focal or submucosal masses or ulcers were seen. The mucosa was erythematous, and there were no features of portal hypertensive gastropathy. The stomach was deflated and water was instilled. On gastric pull-through, there was increased thickness of the gastric wall in the mid to proximal stomach. The individual gastric wall layers were preserved, and the thickening appeared confined to the deep mucosal layer. No anechoic tubular structures suggestive of gastric varices were seen. Five layers of the gastric wall are seen on EUS. The two mucosal layers are bright and then dark. The submucosa is bright and the underlying muscularis propria dark. The fifth layer, corresponding to the serosa, is bright. The question is, what is the most likely differential diagnosis? A. Linitis plastica, B. Gastric mold, C. PPI-associated gastric mucosal hypertrophy, or D. Menetrier's disease. Biopsies were taken to sample the abnormal mucosal layer. Multiple fundic glands were seen on histology, and a diagnosis of hypochloridia and hypergastronemia secondary to chronic proton pump inhibitor use was made.